Fungai.
Thank you, Dr. Shawa. So I was explaining to Dr. Shawa that initially I wanted to present on a clinical presentation of two patients that I got. One was a younger patient. One is a younger patient. She's 26. She had a previous septic miscarriage about 3 years ago. And then following that, she's had subfertility. So when they managed the septic miscarriage, she had a delayed DNC because of the septic shock. And then when it was eventually done, she says she was quite sick and she had to stay in hospital for almost 2 weeks after that. And since then, she's been failing to conceive. So when she came, the initial thoughts were centering around Asherman syndrome or maybe intra-abdominal adhesion. So we had planned to do a laparoscopy together with a hysteroscopy just to see what's going on. Unfortunately, I did not get good pictures. So I decided to not make it a clinical presentation and just go back to the basics of hysteroscopy, because also that's the level that I'm at with the winners program, just looking at the very basic equipment, media, and things like that. The second patient is a 59-year-old who presented with postmenopausal bleeding. What was so significant for me about these two patients was I think I did them about a week apart, and the inside of their uteruses looked the same, with significant atrophy. So for the 59-year-old, it was fine because she just had endocervical polyps, and that was it, nothing else. The endometrium was very thin and atrophic. But for the 26-year-old to then have the same appearance of the endometrium, for me, was very discouraging. So hopefully someone can make a comment of what would be the next steps fertility-wise for her, considering she's a 26-year-old para 1. So today I will just look at the basics of hysteroscopy. Please let me know if my slides are changing. So hysteroscopy is a minimally invasive procedure in which we use a telescope or hysteroscope and we insert it through the vagina and the cervix to be able to visualize the inside of the uterus. And this can be for diagnostic or treatment purposes. The basic equipment include the scope itself, a light source, and distension media. The indications include abnormal bleeding, which can be pre or post-menopausal, endometrial thickness, endometrial thickening or polyps, submucosal or intramural fibroids, intrauterine adhesions, Mullerian anomalies, retained IUCDs, retained products of conception, sterilization, as well as endocervical lesions. There are alternatives that we have to that we can use instead of taking a patient in for a procedure, whether it's outpatient or inpatient, and those include an ultrasound, which can be enhanced by saline infusion or HICOSI or endometrial sampling and HSG. But the advantages of doing a hysteroscopy as the initial evaluation is that you're combining the investigation together with the treatment. And it also avoids the missing of focal pathology as compared to blind endometrial sampling. And besides using it as an initial evaluation tool, we can also use hysteroscopy to further evaluate and treat lesions which have been identified by other imaging studies. We can confirm the absence of disease in patients who have persistent symptoms where we've done other imaging and it was apparently normal. And we can also use it to actually treat and investigate abnormal imaging findings. Hysteroscopy, however, cannot be used to assess myometrial disease or tubal pathology or any external uterine contour. So for patients who are being investigated for subfertility, it is not enough to do a hysteroscopy alone. Hysteroscopy can be done either as a panoramic or direct view, in which we use a distending medium to allow a global view of the inside of the uterus. And this can either be a gas or a fluid medium, and the image is well illuminated, and there's excellent contrast and resolution when you use a medium. The other way is to do contact hysteroscopy. This is not as commonly done because there's no distending medium, so you can only see what is directly in front of you and the tissue which is in direct contact with the scope. That's as far as your view is concerned. So you would have to slowly put in the scope and visualize the different parts of the uterus as you go. The shortcoming of this is that you may miss some pathology, so that's why it's not commonly done. This being a minimally invasive procedure, it is generally safe, even safe enough to do in an office setting. So there's very few contraindications. However, we should avoid doing hysteroscopies where there is a viable intrauterine pregnancy. So before you do it, you want to confirm a negative preg test as well as doing an ultrasound to be sure of it. You also want to check to rule out any active pelvic infection. And the patient should not have cervical or uterine cancer. And there are some comorbidities that you may need to be wary of, especially if the patient is unstable, such as heart disease or they have an active bleeding diathesis. The instruments that we use for the scope itself, it is in 3 parts. That's excluding the external sheath. So that's the eyepiece at the end. And with the old scopes, you could actually use it and look directly through the scope itself, through the eyepiece itself, without us using the camera and seeing the images projected somewhere else. And then there's the barrel, and then the objective lens at the end. So the scope includes the telescope, and then the telescope being this bit, and then the sheath, especially if it's an operative piece. There are now some operative and diagnostic hysteroscopes that come without a sheath, and the advantage of that is in reducing the outer diameter. So the two dimensions that we need to be mindful of if you are ever going to order a scope unit for yourself, you want to consider the outer diameter as well as the working length. So the outer diameter, it includes the width of the barrel, including the sheath, if the scope unit comes with an external sheath. And for diagnostic scopes, sometimes the sheath is not there, making them much thinner. So the diameters can range from 2.7 to 10 millimeters, and the smaller the size of the outer diameter, the more comfortable the patient is, and the less likely you are to need analgesia or anesthesia for the procedure. So smaller diameter scopes are very good for an office setting. The working length can range from 16 to 30 centimeters, and this measures from the eyepiece to the objective lens. The difference in the length is more for the surgeon's comfort. The longer the scope is, the easier it is for maneuvering, so that you're further from the patient. And it's also useful where you are doing a case where the patient is obese, so you would need a longer scope. So most standard scopes now come as the 30 millimeter ones. I mean the 30 centimeter ones. So just to compare diagnostic and operative sheets, so they will both come with stopcocks or ports for the installation of distending media. And then for some diagnostic hysteroscopes, you can be able to input instruments that can be used for biopsies or retrieval of foreign bodies through the same port as the one for instillation of fluid. And so diagnostic procedures tend to be done with the ones with a smaller outer diameter. And then for operative sheets, they tend to be bigger. And these are used to remove endocervical or endometrial lesions, whether they're myomas or polyps, and to do other intrauterine operations. So they can have operative sheets where you insert the instruments through separate channels, or you can actually have electrosurgical resectoscope or a morcellator. Simpler sheets will use the same port where the distending medium is going through, and that's where you also insert your instruments, whereas more advanced sheets will have 3 channels where you can actually insert 2 operative instruments at the same time, and one for instilling the distending fluid. So you can also have sheets which allow for dual port, which have dual ports to allow for continuous laminar flow of the distending medium, and then that can continuously clear the blood and debris to allow your visualization to remain good throughout the procedure. And operative tools that can be used include scissors, grasping forceps, biopsy forceps, or punctate electrodes. So some systems will actually come with sheets that have tools that are permanently attached to the barrel. And the disadvantage of that is that each time you want to use a tool or remove anything, then you have to remove the whole scope together with the tool. Whereas the sheets which allow you to put in your scissors or your forceps, you don't have to remove the whole scope each time. So resectoscopes, they're typically used on a 7 to 9 millimeter sheath, and they use radio frequency electrical energy, which may be monopolar or bipolar. If you're using a monopolar resectoscope, then the patient has to be grounded and you need to use a non-conducting medium. If you're using a bipolar resectoscope, then you can use electrolyte distending medium, and I will go through media a little bit more. Radio frequency tools can be a loop, which is used for resection or cutting. You can also have a roller ball for coagulation or ablation of the endometrium, and you can also have vaporizing electrodes, and these are good for when you are vaporizing the lesion, so that you don't need to remove floating debris of the tissues that have been dissected off. But this is not good if you desire a histological diagnosis. So you would then have to use either the loop or a loop to dissect out your lesion without using the vaporizers. Then morcellators use a rotary blade to cut the lesions, and the tissue is then aspirated through the morcellator itself. They work on a 6, 7, or 9 millimeter scope, and they can be inserted through the working channel. The morcellator does not use radio frequency energy, and so they do not coagulate any bleeding vessels that may be encountered during surgery. So the types of scopes that are there, you can either have a rigid scope, such as the one with the blue background, semi-rigid, which may have a degree of movement along the barrel, and then also the flexible scopes. So most scopes are actually rigid. Most of the scopes that people use are rigid, but with narrow caliber scopes, which are less than 5 millimeters, these may come as semi-rigid or flexible types. The rigid scopes are associated with more intraoperative pain, but they have been found to have better optical quality, and they cost less than the flexible types. The flexible hysteroscopes are favorable for diagnostic or operative procedures where there is an irregular shape of the uterus, or where there's extreme retroversion or antiversion, which is not correcting when you pull using the tenaculum. So you may want to use a flexible scope. The disadvantage of the flexible scopes is that they are very fragile and they are more expensive. So greater care is needed in taking care of them. And they also tend to come as a smaller, with smaller outer diameters. So they can actually be used quite well in an outpatient setting. Yeah. Then in terms of optics, like I said, you can have direct visualization from the eyepiece itself, or for a more comfortable view, you can attach a camera setting to the eyepiece. And so there are some, and then that can be projected onto a monitor or a TV screen in the room, which makes it easier for everybody else to follow the procedure, or to make recordings of pictures or videos. There are also some scopes which come with, such as Endosee, it comes with a camera attached to the barrel itself. So it's the one unit, the barrel together with the small camera that it comes with. So you'll find that higher quality cameras are usually on the larger outer diameter hysteroscopes. And hysteroscopy is monocular because it's just one eyepiece, and this gives little depth perception. When you're using the scopes, you can decide to use either a 0 degree, 12, 15, 25, 30, or 70 degree lens. The 0 degree scopes give a wider angle of view in line with the barrel itself, and so there's less need to move the scope left or right to be able to visualize. However, angled scopes are useful for better peripheral view, so you can turn it to the left or to the right for easier visualization of the peripheries. Light sources are through reusable fiber optic cables, and the light source is either tungsten, halogen, or xenon. Xenon is more superior in terms of less heat generation and better clarity. They say it gives a softer light. And so for people who do a lot of procedures, it's easier on the eyes, but it is more expensive than halogen, which is more commonly used. The intensity of the light is generally lower than what is used in laparoscopy. And that's also because of the distance in the uterus that you are trying to visualize. Distending media, when considering which one to use, you want to have a medium which allows clear visualization, is non-conductive, to avoid electrocautery injury to the uterus itself and surrounding organs. And you also want your medium to be inexpensive. And because the medium will be absorbed into the body, we want that medium to be non-toxic, hypoallergenic, non-hemolytic, isoosmolar, and allowing it to be rapidly cleared by the body. So we can have either fluid or gaseous medium. And the studies have shown that fluid medium is actually associated with less pain. The gaseous medium that can be used is carbon dioxide. And this is the only one that is used for hysteroscopy. It is solely used for diagnostic hysteroscopy because in an operative setting, gas bubbles are going to be formed when you've cut through the blood vessels, and this will then occlude visualization. The advantages of using carbon dioxide, though, is that it gives a very clear field of view and gives actually a wider angle of view compared to liquid medium. And it is rapidly absorbed. It has proven safety for when it has been used for tubal patency over the years, and it is widely available, and it also makes the cleaning of instruments easier compared to liquid medium. it should be insufflated using the specific hysteroscopic insufflator, because the hysteroscopic one has a slower infusion pressure as well as rate of infusion compared to a laparoscopic insufflator. So if you use a laparoscopic insufflator when doing hysteroscopy, it will push in the carbon dioxide at a pressure which is too high, and the volumes are too fast, therefore increasing the risk of gas embolism. Fluid medium may be low viscosity, and that is what is now commonly used because of lower risk of complications. High viscosity fluids such as dextran were used in the past, but there were higher complications, a higher risk of complications like electrolyte imbalance, anaphylaxis, and DIC. And they also ruined the hysteroscopic equipment. So the fluid can either be electrolyte, fluids such as normal saline or Ringer's lactate, or electrolyte poor such as glycine, sorbitol, or mannitol. The choice of the fluid depends on whether you're doing a diagnostic or operative procedure, and also on which equipment you're using in the procedures, whether it's monopolar or bipolar. Electrolyte containing medium cannot be used with monopolar instruments because it will conduct electrical current. So that should be that's what you use to determine which fluid you're going to use. Electrolyte containing media are isoosmolar, so they will not disturb the osmolar balance between the intracellular and extracellular fluid, and therefore only when you have a very large fluid deficit, that's when you are more likely to have complications with these fluids, with an increase in extracellular fluid volume resulting in volume overload. Whereas electrolyte poor solutions are hypoosmolar, and therefore are at smaller volumes, they give a higher risk of fluid absorption. So fluids such as glycine and sorbitol are hypoosmotic, as I said, and they are also hypoosmolar, whereas mannitol is isoosmotic. So procedural risk factors for excess fluid absorption and resultant hyponatremia depend on the type of procedure. If it's just a diagnostic procedure, you're less likely to have fluid balance problems. But where it's operative, because of the cutting through the vessels, there's intravasation into the blood vessels because of that, and also because we are using the more fluid volume itself at higher pressures, and there's a risk of visceral perforation and prolonged operative time. So there's also that risk of increased fluid absorption. Operative procedures are associated with higher risk of excess fluid absorption compared to diagnostic procedures. So during the procedure, fluid inflow and outflow should ideally be controlled by the person doing the scope, and that's through if you have a unit that can allow you to control your fluid inflow, and then you should have someone assigned to monitoring the fluid deficit. So the surgeon should be updated, especially when the fluid deficit between what has gone into the patient and what has come out. When the deficit approaches 500 mils, then the surgeon should be alerted, and at that point the team will have to assess where they are with their procedure and decide on whether to continue or to abandon the procedure. The scope has an you can have a dual outer sheath which allows for continuous laminar flow, inputting and out, and as well as suctioning out the fluid so that you can then collect it and monitor what is happening. Unlike where most of the systems that we use, which don't have the the vacuum system, which allows you to collect all of the fluid coming out, and then you have fluid which is lost into the drapes and towels and on the floor. So the advantages of automated systems is that you can continuously monitor the fluid deficit, and you can preset your limits on what you want the fluid deficit to be, and then it will automatically stop the inflow if that deficit is reached, and it can then measure and titrate intrauterine fluid pressure as well, and it also reduces the risk of air embolism. We need to titrate intrauterine pressure so that we are able to manage bleeding. It will help facilitate the resection of endometrial lesions and decrease the chances of false negative views of the endometrial cavity. So when you start your insufflation and you have a very high pressure, it might actually flatten out any small lesions that might be there and give a false negative result for your scope. So at times, if you find you have gone into the uterus and it's not in keeping with what you were expecting, you can deflate the uterus, and while with the scope still in, you suction out some of the fluid, and then you monitor to see with a reduced intrauterine pressure, is there any lesion that you can now see. So you want to maintain your intrauterine pressure slightly above the patient's mean arterial pressure. That's around 70 to 80 millimeters of mercury. Higher pressures should only be used for a very short time, where the patient is maybe bleeding, or where there's very large clots and debris, or where the uterus is just not compliant. But we know that higher pressures are going to increase the risk of complications. So fluid overload, I'll just go through a couple of complications that can happen with the media.
Your time, Dr. Myocha, is finished.
Oh, okay. I was actually done with the basics.
Oh, then you need to start concluding.
Okay. So in conclusion, really, I just wanted to go through the scope, the different parts of the equipment, and the cautions that we need to take, and just the basics of that. So yeah. The rest I can always discuss at a later. The complications really can always be presented at a later date. I can actually stop there, Dr. Shah.
Okay, thank you very much. Any comments from the group? Anybody who has got any comments? I would want comments from the part twos, those who are going to write. Felix. Oh, Sifanyetso, I see you have got your mic on.
Yeah, no, I just wanted to say that it was quite a great and extensive presentation. Thank you.
Okay.
I don't have any further comments. On this, because there's a lot that I've learned, but yeah, thank you.
Felix.
Hello, Dr. Shawa.
Yes, what's your comment?
Thank you for the presentation, Dr. Myocha. I actually don't have a question, but I thought maybe she would talk about things like preventing complications, especially fluid overload, synechia, which she touched on briefly, but maybe we can discuss that. I don't know, Dr. Myocha.
I think it's me who actually stopped there, because she wanted to actually get there, I think. Well, Dr. Myocha, you can answer.
Okay, thank you very much, guys. So with fluid overload, the problem, arises where you've had a very long procedure or where you've used too much fluid and you have not been monitoring your fluid deficit, and particularly if you're doing an operative procedure. So in terms of operative principles, you want to use isoosmolar or electrolyte fluids, which then means you have to use bipolar tools and not monopolar. And you want to limit your time of operation. There's no evidence to say this is the threshold, 1 hour, 30 minutes, 2 hours. There's no threshold on time, but you are progressively monitoring the patient as you go. You want to closely monitor the fluid deficit and maintain the lowest intrauterine pressure that achieves excellent visualization. You want to also limit I repeated that point about the surgical time, and use of vasopressin into the intracervical injection of vasopressin has actually been seen to improve the chances of, to reduce the chances of fluid overload occurring. GnRH analogs pre-surgery have been proposed, but there's not yet enough evidence to get this into general guidelines. So yeah, I hope that answers you, Felix.
It does, thank you. What about things like preventing intrauterine adhesions, especially if you are doing operative hysteroscopy? I think we have been told of intrauterine devices, barriers, and so forth. Do they actually work, and what should we be using?
So I just briefly looked at that, but not as part of my presentation. So none of, I didn't see strong evidence of the benefit of in putting an intrauterine device. I don't know, maybe one of the mentors can comment, but I didn't really go into the details of that because I was just focusing more on the media and the tools.
We have one of our, those part twos, Michael.
Hello, Dr. Shah, how are you?
Yes, how are you? The use of the barrier methods or the methods of preventing adhesions. I think you should be an expert on that.
Yes, so yeah. So the studies that have been done have noted that the use of levonorgestrel intrauterine device as compared to the copper T. So the levonorgestrel reduces the inflammatory process that then results in the formation of adhesions. So that has been found to be quite useful. However, there are some people who have actually tried to use the copper T, and the results have not been very pleasing, but yes, it has been noted to also reduce adhesion formation after operative hysteroscopy. Thank you.
Sorry, Mike, can you just patient selection for use of that, in which is that across the board? If you've done,
that's for patients where you are doing, say, myomectomy, those with submucosal fibroids, and as well as those who already have, say, Asherman syndrome, where you are doing adhesiolysis. You then need to have an intrauterine device for that, for those patients. It's not for everyone.
And so he also asked about barrier methods, and I saw proposals of intrauterine inflation, post-op balloons, things like that.
The other things are really experimental. They've not been proved to be effective.
Okay, thanks.
Yeah, you're welcome.
Thank you.
I think Rendani must comment on this from a reproductive medicine point of view. Dr. Chikosi. Or Dr. Nzenza.
Hello, how are you? Can you hear me?
Yes, Rendani, yes.
I mean, from us, from the reproductive point of view, there's, I mean, the using even Mirena or your Metrogel, your estrogen, your bulb, there's nothing superior to each other. It's about what you have. There's no study which shows the other one is superior to the other one. If you look at evidence, now it depends on what you have. When you use what you have, there's nothing which is superior to the other one. I mean, if you have more of your myomectomy, most people are. I will tell you that you just have to go back in 6 weeks' time and check if there's Asherman's or not. But there's nothing superior.
Okay, thank you. Dr. Nzenza?
Hello, everyone. Yeah, I think there's also, you can use hyaluronic acid, which is in the suprafilm, which actually can coat your working area and reduce the adhesion that can happen between the two surfaces. It takes a little bit of time for it to be degraded, and it allows for the healing to happen without actually synechia happening. I think that's one of the other things that can be commented.
Any other comments? Chipo?
I mean, the other thing to just say, people must remember that endometrium is an organ on its own, which means that even today, we're struggling to get something to repair the endometrium in terms of if you damage it. I mean, if you look at it now, fresh person plasma are now in something we're using in terms of increasing your endometrium when you damage it, if someone have consistent thin endometrium. Now, whenever you operate patients, just bear it in mind that endometrium is an organ in its own, and if you damage it, we don't have current thing which work in terms of repairing it for fertility, which means if you damage it too much, there's nothing which you can do to improve it in IVF. They must just bear that in mind.
I really like the fact that you describe it as an organ.
Yeah.
Oh, welcome, Taku.
Hello, Dr. Shaun. Thank you. Sorry I'm so late.
No. We must congratulate you for doing very well in Cape Town.
Thank you.
Dr. Gwanzura, we only have 2 minutes left. Any comments?
Thank you very much, Fungi, for the very interesting presentation, a very good revision with extras for some of us. My comment was going to be on the adhesion barriers. I think attending the Pelvic Floor Foundation webinars, they bring a lot of speakers, many speakers who speak about hyaluronic acid. Yeah, it's a tongue twister, and they seem to be all in support of it. I don't know whether it's locally available. The very few hysteroscopies I've done, we haven't used an adhesion barrier, perhaps because the women were postmenopausal. What I was wondering about, Fungi, though, about your presentation, you had said the 26-year-old's uterine cavity looked like the postmenopausal woman's. Did she have synechia, or was it just absolute atrophy? I can't picture it in my mind.
She actually didn't have any adhesions, intrauterine or abdominal or pelvic, because we also did an laparoscopy. She didn't have any adhesions. Sorry, I forgot to mention that she had a scar, like an indentation on the posterior wall of the uterus, probably from a perforation during that procedure. Yeah, but other than that, the endometrium was just very thin, very white, like, yeah.
So what are you going to do?
So we're waiting on sending her to a fertility specialist, but actually that's why I wanted to present her and maybe get other people's view on in such cases, now that we are saying that the endometrium is an organ, and once it's damaged, it's damaged.
Did
I
you
guess
sample it for TB?
Sorry?
Did you sample it for TB?
No, we hadn't asked for a TB.
No, please, next time just do that. It's a very common thing. Now, next time just take it and sampling and send it for TB culture. Okay.
Okay.
Thanks.
Okay. Sorry, what is the handling of the tissue when you want a TB culture?
Sorry?
What's the handling of the sample? We take the biopsy and put it in what sort of container?
I would like
just
to.
a plain, just a plain container, or do we use the formalin? Do we use?
You don't use formalin.
I can't use formalin for a culture.
No, they don't need formalin at all. You can use plain, or what else? I forgot something. I don't want to lie to you. I'm not remembering on top of my head. I'm now also in a conference in Italy. I'm just sitting in a lunchtime. I'm in an ISSA conference now, but I'll remember it. I will tell you next time.
Okay, thank you.
Right, for TB, you need 2 specimens. One, you put it in formalin where they will give you the histology. And then the other one, it's a normal culture, which you just put in normal saline, and then they can go and culture it. So you just need there is no specific, as long as you know that the one in formalin will give you the histological changes, because they should be able to show you histological changes on a TB. And the other one is just a culture where they will do the Ziehl-Neelsen staining and other things.
Okay, thank you.
Okay. But that is if you suspect it.
Yeah, because I mean, when we send it most of the time, we find that some histologists will tell you that they can't really culture TB. Sometimes it just looks like TB. Then you just treat. I mean, we find that some people can't tell you that it's exactly TB, but they just say it looks like it, and you just treat.
Okay.
And
right,
would
I
the
think
endometrium regenerate? Sorry, Dr. Shawa.
No problem. That's fine.
Would the endometrium then regenerate after the TB treatment?
We've seen patients with amenorrhea where you treat them for TB, and some of them you get endometrial function post that. Which means that it does regenerate to functionality. That's the answer. Some patient, I don't know the statistic numbers, but yeah, it does.
Thank you.
Okay, thank you. I think in the absence of further comments or questions, thank you very much, Dr. Myocha. And remember, the purpose of these discussions is to stimulate more discussion. We can never exhaust all the possible questions and answers, as long as we are able to stimulate discussion, and that is the main purpose of it. And I think the mentors, none of them, I think, did join. So we will arrange for those people who are going to write for your part 2s. But otherwise, I think at this point, we can close the meeting.
Thank you, everyone, for your time.
Thank you, Dr. Myocha. Thank you, everyone.
Dr. Myocha.
Thank you. Good
Thank
night.
you. Bye.